Hello, everybody. Welcome to Grand Rounds. Great to have you all here, and good to have a familiar face, Dr. Lindsay Jubelt, who I had the pleasure of working with when she was the Chief Medical Officer and Vice President of Operations at Mount Sinai Solutions, which is the Sinai direct-to-employer business, and during which time she's done a lot of work with the sort of intersection of business and medicine, things like quality, value-based contracting, risk prediction, data analytics, operational effectiveness, etc. And we lost her to Boston, to my hometown, where she's now the Chief Population Health Officer for Mass General Brigham and the Chief Medical Officer for Mass General Brigham's insurance entity, Always Health Partners. And she's going to talk to us today about a small topic, improving health in the United States. Dr. Jubelt.
Thank you very much, Dr. Weissman. Well, what a pleasure to be here today. And for those of you on the line, I moved to Boston this weekend, and I was just telling Dr. Weissman and Dr. Berger that this is the first test of my internet in my new home. So please bear with me. If it cuts out, I'll hop back on. But excited to be with you here today to talk about the #1 strategy to improve health in the United States. So I know you guys are all on the edge of your seats wondering what that is. So excited to talk about it. We're going to talk about a lot of things. I put on our learning objectives here. I also want to say that I have no conflicts of interest, so conflict-free. I'm going to start by just talking about some of what do we know about health in the US and comparable countries. So some of these facts are known to many of you, but good to ground us as we think about the broader discussion. So US spends more money than any other country in the world, yet has poorer health outcomes. Not only do we rank lower, spend more money, but we also have more premature deaths, so more loss of life people before the age of 50 than in comparison countries. When you look at why we're losing lives, it's to not just one particular cause. So someone say, oh, maybe you have more drug-related deaths or more firearm injuries. When you look at causes of death, we have more of it in every category than all other comparable countries. So that includes communicable and nutrition diseases, drug-related causes, perinatal conditions, intentional injuries, cardiovascular disease, unintentional injuries, then putting it all together, all causes. So we're not just best in one area or worse in one area, we're worse in all of them. So good news is there's a lot of good things that one can work on to help US get better. We also, interestingly, have the highest environmental burden of disease. So if you look at all of these other countries that are comparable, we have the worst environmental conditions with us there at the top. We also have the biggest burden of drug abuse disorders, higher in the US than comparable countries. And we have the highest disease burden from motor vehicle incidents. So just to pull out a few of areas that we're not so good in, environmental conditions, motor vehicle accidents, and drug use are a few. And then firearms being another. So many things that makes it unsafe to be an American citizen. So lots of things one can do if you want to think about improving health outside of just the four walls of a hospital or a practice. So I want to switch gears now. So as you can see, we have a lot of things to get better on. I want to talk a little bit about the relationship between access to healthcare and health. All right, so the first area I want to talk about is the Oregon health insurance experiment. And this occurred during the Affordable Care Act, when states were given additional funding from the federal government if they expanded their Medicaid program. And so Oregon chose to take this additional funding from the federal government to expand their program. However, they had more lives that could benefit from Medicaid than they had dollars to spend. And so how were they going to distribute Medicaid fairly? So they decided to set up a lottery, and they had a lottery drawing of about 30,000 people that they were going to offer Medicaid to. Well, turns out this is a great way to study the effects of Medicaid on a population, because it was essentially a randomized controlled trial. One does not get to do that often when it comes to health insurance. And so they gave out this Medicaid eligibility to these families and looked to see what the effects were on health. And what they saw after a few years of having Medicaid is that it did increase the use of healthcare. Increase in ED visits and an increase in the use of preventive health, such as mammograms, colonoscopies, and the like. However, they did not, there was no effect on health outcomes. So no effect on health outcomes of hypertension, hyperlipidemia, or A1C levels. So we increased access to care, but not necessarily outcomes. And these outcomes are not distal outcomes for which it takes many years to see an effect. You know, hypertension, you should be able to start a blood pressure medicine, and 20 minutes to an hour later, you should see an effect. So somehow people are getting access to health, but weren't seeing the measurable impacts on getting access to healthcare, but not seeing measurable effects on their health. There was seen a decrease in the likelihood of screening positive for depression. So it seemed like it did have some effect on mental health. While there were not meaningful outcomes on health, getting access to Medicaid did have economic outcomes and significantly reduced financial strain for a family. So reduced the likelihood of having a medical bill being sent to a collection agency by 25%, and reduced the likelihood of having any out-of-pocket medical expenditures by 35%. All right, so this randomized controlled trial showed that Medicaid coverage generated no significant improvements in measured physical health outcomes in the first 2 years, but it did increase the use of health services, raise rates of diabetes detection and management, it did have lower rates of depression, and most significantly, it reduced financial strain. That's the effect of getting access to health care, increases use and decreases financial burden. Now I want to shift to talk about a different policy change. This was the moving to opportunity policy that was launched in the 1990s under the Clinton administration. And this was a social experiment to test the effects of neighborhood on social and economic outcomes. Under this experiment, the Clinton administration randomized 4,600 families living in high poverty public housing projects into 3 different arms. One was a control arm. One was a traditional housing voucher for which you got like a Section 8 housing voucher to get housing. And the third was a more robust housing voucher for which you had a housing voucher that could get you access to low poverty neighborhoods. You were also set up with social workers and other support to help you find houses in those neighborhoods. And the outcomes here were interesting. The intention of this was by getting people access to better neighborhoods, families access to better neighborhoods, the hope would be you'd see improvement on the economic well-being of the families, that they'd have more jobs, better financial outlook. What they saw were that there were no effects on adults' employment rates or on their earnings. However, they reported feeling more satisfied and feeling safer living in these neighborhoods. Interestingly, there were effects on the children. So if the family moved when the children were younger than the 13, there were financial benefits to the children. So they had a 31% higher income, $300,000 on average higher lifetime earnings, and 32% more likely to attend college. But notably, there were effects not on the parents' financial outcome, but there were effects on the parents' health outcomes. So they had lower rates of obesity and depression. And as the study went on, it turned out that they had lower incidence of hypertension and hyperlipidemia. So all those health outcomes that the Oregon health insurance experiment intended to find with getting access to healthcare, it did not. And instead, getting access to healthcare improved your financial well-being. Where here, where we thought we were moving families to neighborhoods to improve their financial well-being, didn't do so immediately for the parents, but it did improve their health well-being, their health outcomes. So very interesting. And I think this speaks to what we all know are these social determinants of health, that health is driven only to some extent by medical care, estimated 20%. Health behaviors, 21%, but the whopping majority is driven by social characteristics, an estimated 55%. Okay, so social determinants are the conditions, looking at this slide, are the conditions in which people are born, grow, live, work, and age. And they include factors such as social economic status, education, neighborhood, physical environment, employment, and social support networks, such as access to healthcare. All right, so there is a direct correlation between income and health, and that's very important to note. And this study by Raj Chetty found that the gap of life expectancy of about 15 years for men and 10 years for women when comparing the most affluent 1% of individuals with the poorest 1% of individuals. To put this into perspective, the 10-year life expectancy difference for women is about equal to the decrement in longevity of a lifetime of smoking. So women, that 10-year difference, if you're poor versus wealthy, that's about equal to a lifetime pack a day smoking history. So thinking about this, if it's income that is driving a lot of our health outcomes, and our neighborhoods, living in poor neighborhoods that are driving a lot of our poor health outcomes, we need to appreciate that we have a higher degree of income inequality in our country than in other comparably wealthy countries. All right. And then given the multitude of available community measures, communities often have difficulty agreeing on which measures to use to identify what are considered cold spots, or ways to identify what are kind of neighborhoods that could lead to poorer health. So one way to find a common language is to use what's called a deprivation index. And other countries have, such as the UK and New Zealand, have looked at deprivation indexes to solve this problem. And so this is an example developed here in the US, is a social deprivation index, which is composed of the various different dimensions listed in the table above. And what this finds is that even if you yourself don't have these factors, if you live in a neighborhood prevalent with these factors, you're likely to have poorer health outcomes. So if you live in a 2-parent family, yet a lot of the families in your neighborhood have single parents, you yourself are going to have poorer outcomes. So these are things that are not attributes of the individual, but rather attributes of the neighborhood. Somehow these disadvantages on the health persist even after taking out of the individual characteristics of the individual, these characteristics persist. So when we think about the US spending a lot of money on healthcare more than other countries, we also need to think about what the amount of money we spend on social services. Great, sorry about that. So the US spends more money than any other country on healthcare. But when we put into account how much we spend on social services, we see a very different picture. Okay. When we look at see how much the US spends on healthcare, we spend more than any other country in the world by a long shot. But when we look to see how much we spend on healthcare plus how much we spend on social services, a very different picture emerges. In fact, we're right in the middle of the bunch, and you can see we're right here. Hopefully you all can see my arrow. We're right here in the middle of the pack. So it's not
No, I'm gonna have to.
Oh, I'm back.
Sorry, looks like we lost you. Are you able to share your screen again?
Yep, sorry about that, everyone.
That's okay.
Okay. All right. Did you all see this screen, the prior one?
Can you go back one slide?
Yeah, absolutely. Let me see if that'll work. Did you hear me talk about this one?
We're on this one, yep.
Okay. Did you hear about the ratios?
Not yet, no.
Okay. So when we look at spending in the US compared to other countries, when we look at how we spend a lot more on healthcare than any other country in the world. Yet when we look at how much we spend on healthcare and how much we spend on social services together, when you add those up, we're actually right in the middle of the pack of other comparable countries. What is just so different is the ratio. We spend a lot more on healthcare than we do on social services. Our ratio is very different. You can see this bar here In the middle is the US, where that ratio looks so different. When we look at the ratio of social services to healthcare spending across the country, a very interesting pattern emerges, where we see that those states that spend more, have a higher ratio of social service spending to healthcare spending have better health outcomes than those who spend where the ratio is a lot more healthcare spending than social service spending. So there's been a lot of research showing that greater investments in social services can improve health outcomes and reduce healthcare costs. And research has shown this across countries that higher level of spending on social services is associated with performance on several population health measures. Some of those measures we looked at the beginning: life expectancy, diseases, environmental pollution, all of these things. When you spend more money on social services, those health outcomes get better. And so within the United States, these higher ratios of social services, including public health services, is statistically associated with better health outcomes at the state level. And this was found across a variety of health outcomes, including obesity, asthma, mentally unhealthy days of activity limitations, neonatal mortality, lung cancer mortality, even when accounting for states' socio-demographic, economic, and political characteristics. So even when we try to take those account, this pattern persists, that there seems to be something about this health care spending and social service spending ratio. All right. So, and again, this makes a lot of sense. If social determinants of health make up a much larger proportion of what drives health outcomes, it would make sense that investing more in that part of the pie versus health would lead to better health outcomes. Many have questioned then, what's going on here? What is happening at a neighborhood level that could cause a person, even who doesn't have those characteristics, to be unhealthy? And some have questioned whether the links between neighborhood conditions and health might be largely a function of characteristics of the individuals living in the neighborhood rather than features of the neighborhood itself. But some have argued, no, it is this feature of the neighborhood. And that's where we saw that social index that seems to be something about these neighborhoods that makes people unhealthy. And so what is it? Well, a few different things could be going on. One is the social processes. So the extent of social networks or collective socialization around norms or role models, or the influence of peers, competition between groups, relative deprivation is a form of keeping up with the Joneses. So something about sort of peer and social networks that has an effect. Another could be environmental factors, exposure to violence or the area's physical surroundings, from the broken windows theory to environmental pollutants. And we know that this country has more of those than other comparable countries. So in neighborhoods that are even worse, they would certainly have pretty bad environmental factors. Next could be geographic forces. The distance of a neighborhood to good jobs or its relative isolation in the city could be a factor. And then finally, neighborhood resources themselves, such as access to daycare, schools, medicine clinics, the type of stores, amenities in the neighborhood, supermarkets, liquor stores, may have a connection to individual outcomes. At the end of the day, we really don't know. And it's sort of like trying to fix a disease when you don't know what the cause is. We don't have the right medication or treatment because we don't actually know how much of these are driving the effect on health outcomes. There needs to be, I think, more understanding of that. And these are very hard areas to try to do, randomized controlled trials in. You can't it's very hard outside of maybe that moving to opportunity to try randomizing people to different environments with different factors. Okay. So, so next, I think there have been some concerns that investing in healthcare interventions addressing social determinants over health over-medicalizes individual social needs and may take away from investing in upstream community interventions. So in health, an all policy approach identified ways in which looking at some of the focus on health and non-health sectors. So policies and initiatives in non-health sectors can have impacts on health and equity. A health and all policy is an approach to incorporate health considerations and decision-making across all sectors and policies. And then finally, talking about the Harlem Children's Zone. So one push of one group is to say, okay, well, maybe in all of these other non-health sectors, what we should do is just bring health into them. And so when we're talking about schools or talking about transportation, we should be forcing those organizations to be thinking about health. And that's been one sort of effort to do so. And Harlem Children's Zone is, I'm sure many of you are familiar with it, is an area up in Harlem where the idea there was to take care of the entire neighborhood through the school and address all elements of not just the school, but the family structures and how families were engaging with their children, about how the neighborhood was looking and designing the neighborhood. And so taking into account much more than just the school, but taking into account health into how the school was functioning and the role it was playing into the community. And so that's one sort of way that policymakers have thought about dealing with the social determinants is, well, let's, rather than have the healthcare system take this on, let's have the rest of all the different social service agencies and the rest of society take on health. The alternative is to have the healthcare system address social determinants. The argument here is that we in healthcare are well positioned to identify social risk factors and unmet social needs. And I think that's true. A lot of people come to the hospital or to the ER or to their doctor, and when they show up, we can identify social risk factors. And many, relatively new federal and state initiatives are particularly focused on identifying the non-medical social needs of patients. And then in the shift towards
Dr. Jubelt, looks like we lost you again. I think we lost you again. Oh, you're on mute right now.
All right, great. I'm so sorry, everyone. This is clearly not the time to try out my first internet. So
that's okay.
My first time using this internet. So anyway, so going back to this, so there's a big debate going on right now about.
Sorry, can you share your screen again? For some reason, it loses the screen share.
Yep.
Thank you.
Yeah, so I think there's a big debate going on right now, kind of who should own the social determinants of health. Should it be in the non-healthcare sector where we incorporate health into everything else? Or should the healthcare sector take it on and incorporate social services into health? And probably it's a little bit of both. But I think in healthcare, we feel, some of us feel excited about this. Some of us feel like we're being asked to do a job for which we don't have the tools to do. But it's a bit of a kind of problem that the way our society is structured, that generating health is because social determinants drive so much of it, probably can't be completely done by the healthcare system, yet we're accountable for the health outcomes. And so there's a bit of sort of different government agencies control the funding for different programs, and they're not all working collectively with the shared goal of health outcomes. And that creates a fragmentation in terms of being able to effectively address this issue. Okay. So there are challenges linking, if we in the healthcare world are going to do all of this, there are some challenges linking medical and social services. So for one, there's no management function linking medical and social services. So this is what I was talking about. There's different different agencies within the government that do this, and not one agency is accountable for the funding and the outcomes. There are different funding streams for social services than medical. There's different legislative committees, different research literature, and even just different training and orientation of the personnel. So we look at this from a very different perspective. Neither the medical nor the social services are a single system. In most other countries, these are together as one, and so can make decisions for a society operating together. But here, they're very distinct. We have very limited capacity on the social support service side. We tend to overspend, as that ratio showed. We overspend on medical care and underspend on social services. So this results in not as much capacity on the social service side. So even if we in the medical side are going to be the ones to identify the risks, We don't have anyone to pass the baton to because there's limited capacity on the social service side. And then there's not a single professional taking responsibility for the range of medical and social service needs. So a physician can write a prescription for an expensive medication that may provide little benefit for the patient, but that same physician cannot get home delivered meals for this person, nor can anyone else. You can suggest that happens, and a social worker may be able to help, but it's really not within your professional role to have authority for meal service delivery. All right, so I think that's I think appreciating some of the problems in this country. We've got bad health outcomes. We spend our money in very kind of different ways than the rest of the world does, and it's very fragmented if we're going to try to solve for this. And it's hard for the healthcare system, nor is it efficient for the expensive healthcare system to perhaps take this all on ourselves. We probably won't be successful if we're doing it all alone. What are the implications? I think I want to change gears and talk a little bit about the implications of healthcare costs being so high in this country, because that was where we started at the beginning. We have bad health outcomes, but spend a lot of money on healthcare. So we know that healthcare premiums in this country are high and rising every year. If you look at single family, for family coverage in 2017, it was about $20,000. In 2021, it's above $20,000 for a family of 4. Health insurance premiums for families have increased, or for everyone have increased at a rate faster than inflation. So in this graph below, you can see the orange is healthcare family premiums increasing at a rate that is above that of workers' earnings, which is light blue, and increasing at a rate greater than overall inflation in dark blue. When we look at this country and productivity, this country has been incredibly productive over the past few decades. So our factories and our workers are turning out a lot more widgets and a lot more services than we had going back several decades ago. Yet our wages have pretty much stagnated. And so how do we explain that? What could be an explanation for why, if companies are making more money and turning out more goods and services, why haven't workers captured any of that gains in production? Where's the money going? Well, if economists, a couple of other economists have looked at these, and where this money is going is to healthcare. What workers take home is not just their wages, it's also their total benefit package. So their total compensation is made up of the spending on benefits plus wages. And so these are 3 different economists trying to estimate what total compensation would be over the years. And you can see that makes up the majority of productivity once you add in healthcare. And so rising healthcare costs are keeping our wages flat because the increases in productivity are going to pay for the rising healthcare costs. This is more of a problem for lower wage workers. So if you look at the graphs on the left, that represents a family income in the bottom 40%, versus the figure on the right is a family income in the top 5%. Because healthcare premiums are the same for a family of 4 that is in the bottom 40%, it's at the top 40%, it takes up a lot more. That $15,745 in 2012 takes up a much larger share of that worker's earnings than does for the top 5%. And so this results in an income transfer from the top earners to the bottom earners. And it's been, many economists have said as a result that rising healthcare costs are actually the biggest driver of income inequality in this country, because it results in this income transfer from one to the other to pay for the health insurance. So what are other implications in addition to potentially driving income inequality of rising healthcare costs? Well, there are many. So if we look at what are the effects on employers who have to compete in a global marketplace in order to pay for health insurance for their employees, in order to still make a profit, they have to find ways to make that money up somewhere else. So they typically pass that cost on to workers, and it comes out of the workers' paycheck and their wages. They can also
Yeah, Dr. Jubelt, we were on this slide. Yep.
So they either need to, for a government, in order to, for the state government that has to balance their books each year, in order to pay for rising healthcare costs, they either need to bring in more revenue through greater taxes or cut costs somewhere else. So that means reduced funding towards other services, decreasing benefits, changing eligibility rules for those that are getting Medicaid or Medicare. So, reducing, increasing the age for Medicare or reducing the number of people eligible for Medicaid, or again, shifting costs onto patients and more co-insurance. For consumers, this has meant stagnant wages over the years. It means they're seeing less generous health plans. That can mean reduced access to care with more narrowed networks. It can mean increased out-of-pocket medical expenditures, increased consumer debt. Medical expenditures are the #1 cause of individual bankruptcy in this country, accounting for 62% of individual bankruptcies. It can also mean fewer job opportunities and less job security. So as these companies to compete internationally, many are moving their jobs overseas where they don't have to pay for expensive healthcare, or again, they're shifting to part-time labor, so it can mean less job security. All right, so states don't always make overall budget and policy decisions that optimize the health of a population in a state. So why is that? So sometimes the health of a state's population is superseded by other values, maximizing personal liberty, that the state and the people voting don't feel like it's the role of the government to provide social services and instead want to maximize personal liberty, or they want to minimize the size of government and taxes. Sometimes financial and political incentives to improve health are misaligned. We talked about this a little bit. This wrong pocket problem where the expenses incurred by one agency, such as housing expenses, result in savings on another. So if you were to have better housing, we might have lower healthcare costs. We've seen that with some of the Housing First initiatives, but the healthcare or the health insurance would benefit from those savings, but they're not the ones paying for housing. And so it's a kind of wrong pocket problem. And then population health doesn't always have individual beneficiaries who champion its cause through testifying for laws or for funding political campaigns. Unlike diseases often do, you'll have someone that represents kidney disease or diabetes that goes in front of Congress and testifies. Population health is a bit more amorphous. What is population health and who is arguing for it? And then finally, there's a bit of a lack of consensus about who is responsible for health. Is it personal responsibility? Is it social circumstances? Is it both? And so it becomes a nebulous problem of who's in charge of fixing it, whose responsibility is it? And then I think going back to that, we don't understand, even if we say, okay, it's the neighborhoods, well, which part of the neighborhood? So how do we know what to fix? And so it gets very complicated to make inroads on this. We do know that cross-nationally, looking at other countries, health outcomes are related to social expenditures. So countries with greater social expenditures have better health outcomes. There's a strong relationship between social expenditure and health outcomes across states in this country. Some areas of social expenditure, such as old age spending, appear to be more strongly positively associated with better health outcomes than others. So we know it's not just spend on any social services. We know that some social services are better investments. That old age spending is a great one. And then better health outcomes seem to be more evident when the data are looked at over a longer period of time when social expenditure occurs, often because it takes a long time to translate social expenditures into health outcomes. Typically, we're looking for a quick fix. And some of this is because our elected officials are elected for 2 years and 4 years. So they're looking for something to prove the value of that investment. Some of these things take years to come into fruition. The other interesting thing to note is countries that report in surveys having higher level of trust in each other tend to have both higher levels of social spending and better health outcomes. And so building trust in a community also leads people to want to invest more in social services and leads to better health outcomes. And then higher inequality is associated with an even stronger association between social spending and health outcomes. And so if you have more inequality, that investment in social service spending, you'll have a greater ROI. All right, so given all of this, when we think about how are we going to improve health in the United States, I wanted to turn it over just for having a bit of a discussion to say, what is the #1 strategy to improve health in the United States? I would love to open it up to those that are on the phone. Please unmute yourselves. And would love to get your perspective.
So Lindsay, since people are being shy, I'll jump in here. To me, it seems the #1 strategy tends to be a political fight over expansion of insurance. While I think you've proven that's probably not the optimal strategy, that is, I think, what we continue to argue about here.
Yeah, I think I will say is providers, we're in a very strange position of recognizing some of the social drivers of health, and we see it in our patients, and we see how those things can affect our patients. But I personally, as a physician, don't feel like I have the tools to be able to fix all of this. But somehow, because we're the ones seeing it and measuring it and being accountable to measure it, seems like somehow we've got to figure out what that bridge is to share that back with those that do have the tools. Yeah, but Dr. Berger, I think you're right. We seem to be arguing over health insurance. Yeah, we can go back to the health insurance slide just as a reminder. Let me find it. So what happens when you give people health insurance? It's a very quiet group. I would love, it was my hope, and I apologize for all the internet connection issues, but I don't have the answers for all of this. I'm hoping some of you do. And my hope of having these sort of talks is to stimulate a discussion so that I can learn from some of the great ideas, particularly from the trainees. But I'm curious, especially amongst the trainees, when you think about this and what you're going out there to do, and yet many of us go into this field to improve the health and well-being of our patients, what you think the answers are here. If I was a president of the United States and I was going to fix the health of our country, I don't think it would be just improving access to health insurance.
I mean, I'd probably fix housing.
Yeah.
Thanks for the presentation. One of the concerns about shifting who's going to be responsible is who's going to be responsible for the underfunding, because if it's not funded correctly in the first place, right, then if you assume responsibility for it, it's hard to be successful. So I worry about healthcare taking over responsibility if it's not going to be properly funded. It just becomes another unfunded mandate being placed upon healthcare. I don't know what your thoughts are.
Martin, thanks for that comment, and nice to see you. I agree, and I'm not even sure. Really, I think I don't think we're in the best. We're in a nice position because people show up at our doors to see these problems, but we are expensive. We're more expensive than most other, social service providers. So I'm not sure funding us is the right answer because we are an expensive solution.
Dr. Jubelt, there are a couple of comments in the chat. Some of the residents are without microphones or on computers where they have neither microphones nor cameras working from some of the workstations. So Justin Gasper, a future chief, is talking about improving access to housing and infrastructure to make, I think we should change from to make to give the opportunity for people to be more active in their commute, safe bike lanes, safe walking spaces, green space for commute versus, the way we currently commute.
Yeah, I think those are great ideas. Dr. Weissman suggested the same thing. We build more housing, make neighborhoods better. I think the real challenge here is like, it's like we're randomly prescribing a variety of different treatments, almost like medicines. We have no idea what works, which I think is just fascinating that here we are, we have like the worst health outcomes in, you know, the world of wealthy countries. And yet we have like no clue how to go about solving this.
So Dr. Jubelt, I would say that one of the things that, to Dr. Aaron's point, Dr. Weissman's, as well as Justin, our future chief resident's points, you know, when I think about what do people tout, they tout a couple of different things. Some of it is better outreach. Some of it's better improved use of social services. Your other slide showing that our combined spending on social services and medicine, I think harkens to your point that we're not getting the bang for our buck because we're spending more of our money on health services. That's an inefficient way to fix problems, like having the Henry Ford Hospital buy a building down the block from them to put their 30 most frequent ER people because of the negative payment repercussions, not because of anything. I mean, I will say that I know people at Henry Ford and they're great people, but I don't think they wanted to buy a building just for these 30 people out of the pure goodness of their heart. There were financial incentives. Like, I'm sure the city could have probably done that cheaper.
Exactly. The wrong pocket problem, right? Yep, exactly right. Exactly right. Well, there's a movie I would recommend for any of those interested in this called Show Me a Hero. That I recommend people watching, and I think it gets at some of these issues around sort of America and social service investments. But I highly recommend it's on HBO. It's by David Simon, who also did The Wire and Treme and some others, but it's a good one for those that are interested in some of like, how does America fix these issues? But it's almost like we as physicians and being called to fix a problem that is very deep-seated and probably would be better done by a bunch of urban planners. But it'd be maybe interesting if it's, you know, maybe some of this is like, we as physicians are seeing this and being called upon, and you know, Dr. Berger, as you said, now as the incentives are changing for hospitals and physicians and health systems where they're investing in housing, it's like, maybe we need to be sitting down with the urban planners and the folks in, you know, city governments and having these conversations of what we're seeing, because it would be a lot cheaper for the city probably to house those people than it would be for the hospital. And yet the city is funding the hospital. So I think, you know, one thing I do want you all to be aware of as we switch to these thoughts on social determinants of health, which is so important, is just recognizing, though, we probably cannot and should not be the total solution. Again, and it's not because we shouldn't care about it, but we're not able. It's because we are more expensive. And you know, where Martin was going, where Dr. Aaron was going, if we start being accountable to this, and what Dr. Berger said, we have a pretty hefty kind of tax associated with us fixing this problem, because our health systems are paid more, we as physicians are paid more than a social worker. And so we're extracting dollars to fix a problem for which is underfunded to begin with, that could be more efficiently, like economically efficiently done by having another part of the government pay for it. And so I think while it's good that we're all talking about social determinants, and that's essential if we're going to improve health, I think there's a limit to what we should do because of the economics behind it, because we're almost just furthering the problem by extracting more dollars to fix this problem, because we are an expensive tool to fix the problem. And I don't know what the answer is, but I think it's important for everyone. I want you all to leave this being aware of that, to advocate where I think the dollars do need to be invested.
Dr. Jubelt, I would give another example of the wrong dollars, wrong pocket, wrong strategy. So we have an aging population that increasingly needs to be placed in long-term living facilities. Many people haven't exactly planned for this. I doubt anybody on the call has even really planned for their own future heading towards it. Yet there's no good way outside of incredibly expensive assisted living. There's no good way to move an older person who was living with family that was able to support them and no longer can handle it. These may not be people with a lot of resources and they're overwhelmed. So they come to the hospital seeking help. And Medicare says they have to stay in a hospital at, let's just call a hospital bed $2,500 for us to do nothing a day of expenses. So they're staying, at the most expensive hotel for 3 days to be placed, having social work, physical therapy, and a ton of other people see them, not to mention all our residents or nurse practitioners or PAs and an attending, dropping a physician bill every single day to see them just to get them in to a solution that could be fixed with a better social policy and a different payment structure around social entitlements if we consider Medicare a social good.
Yeah, I agree, Dr. Berger. Those policies they're just so crazy when you're sitting in the middle of them, watching them play out. I think for all of us and for the trainees in particular, advocacy can come in many forms. You never know when you're going to have an opportunity to meet with elected officials or sit with someone that's in a different government agency that sees this problem for a different angle. And I think my hope would be this opens your eyes to have those conversations, to share with them what we see on the healthcare side. But that is, I think, some of what needs to happen is more of those conversations with all of the different agencies, but particularly the medical side coming together with the social service side, more of those conversations together, because we're at the end of seeing the effects of these things, but we are not the best tools to fix the underlying problem. The schools, our different social service agencies. But, as we talked about, that means where is that money going to come from? There are finite dollars. And so there is a limit to how much more healthcare costs can escalate. It's just a sort of downward spiral where healthcare costs go up, we underinvest in social services, leading to worse health outcomes, leading to more healthcare spending. And so at some point there is going to be a limit to that, or, I imagine society will implode or something. But I think it's also recognizing what the implications are of rising healthcare costs on our society. If the biggest drivers of improving health are improving the environment you live in and improving your income, that we learn through that, moving to opportunity. Yet what drives inequality in our country and what drives poor health outcomes is income inequality and rising healthcare costs. There is a solution in here, I think, that can kind of fix it all, which has to do with the amount of money we're spending on healthcare. And so I think it's also recognizing that we are sort of contributing to this fundamental problem. What the number one thing that we can probably do to improve the overall health of our populations in this country is spend less money on healthcare and invest it on the social service side. Easier said than done. I don't think any of us want to go home with smaller paychecks, but I think it's important for us to recognize the direction that our society is headed. All right, very good. I think there are I see a couple other things in the chat. Let me see. Oh, CME credit. Any other questions or comments? All right, well, I do recommend that that movie, Show Me a Hero. And then if folks have additional ideas, please feel free to contact me if you have questions or comments. I think this is hopefully a thought-provoking lecture to get you think beyond just the general, medical care and thinking about broader society and how we're really going to fix population health. But my newish email address, since I'm no longer in the Sinai system, is ljubelt@partners.org. So LJUBELT@partners.org. Please feel free to send me comments or questions. Would happy to engage on this, but just excited to get to have an opportunity to share with you all just some different thinking about population health and social determinants, since that's a topic that is just so important these days, is how to think about what does social determinants mean for the healthcare side, and what does healthcare mean for social determinants in the population health of our country.
Thank you so much for joining us. Have a great
Thanks
day,
for having
everybody.
me. All right, but
It's
please feel
great
free
to
to
see you,
email.
Lindsay.
Nice to see some old friends. Hope you all are well.